Good evening, everyone. Today's lecture is about terminology in histopathology. Young postgraduates who are getting initiated into histopathology, they should know certain terms which are used while describing the slides. And we will go through some of the terms, some of which are general and some of which are in epithelial tissues and connective tissue. Before we go into the terminology, let us know that the epithelia are in the body are of two types: non-keratinizing stratified squamous epithelium, which consists of basically three layers: basal cell layer, prickle cell layer, and superficial layer. And the second type of epithelium found lining the mucosa or skin is keratinizing stratified squamous epithelium. And the layers in keratinizing epithelium are basal cell layer, prickle cell layer, granular layer, keratin layer, and in skin there is a fifth layer which is interposed between granular layer and keratin layers, and this is called stratum lucidum. So we should know the various layers and then we can understand the changes which we describe in the epithelium. Now here is a picture of non-keratinizing squamous epithelium, which is generally seen in mucosal linings of the internal organs. Now if we start from here, we see that this is the basal layer, and above this layer is the parabasal layer, which is the lower part of the spinous layer or the prickle cell layer. And why it is called prickle cells? Because there are intercellular bridges which are like thorns, and that is why it is called prickle cell layer. We can see the intercellular bridges very clearly between the keratinocytes here. And then these cells, these are also cells of prickle cell layer. As the cells move upwards from the basal layer towards the keratin layer, there is a maturation of the cells with increase in the amount of cytoplasm, with increased eosinophilia, and gradually when they reach near the keratin layer, the nuclei become flattened, and in the non-keratinizing epithelium, we see this parakeratotic layer with the presence of the thinned out oblong nuclei. In orthokeratin, there is no nuclear structure at all. That I will be showing later on during the lecture. Now this process of maturation of the epidermal cells or epithelial cells from basal layer to the surface is called maturation or differentiation. And sometimes it is also called polarity of the epithelium. Another term which we will be using and seeing later on is the polarity of the basal cell layer. These columnar cells, they align themselves as a palisade, and the nuclei, they are towards the basal side of the cell. This is called palisading of the cell with polarization towards the basal layer. So these are the terminologies we will be coming across in many diseases or tumors. Now you will be reading that there is epithelial hyperplasia. What does epithelial hyperplasia mean? Epithelial hyperplasia. Hyper means increased, plasia means growth. So increased growth or increased thickness of the epithelium with elongation of the retiridges comprises epithelial hyperplasia. Here, if this epithelium we see that the thickness of the epithelium is gradually increasing when we are coming this side. The retiridges are becoming more prominent, elongated. Some of them are rounded here and some of them are becoming tear shaped here, as we can see here, and everything has a significance as we will be going through, and this is called epithelial hyperplasia. The top layer, if we see, this is containing nuclei, so this is parakeratin. Now, I was describing the polarization of the nuclei. Here we can see that the nuclei are palisaded with nuclei based towards the basal lamina, and that is the polarization. Now you are seeing these blue areas in the epithelium. These are elongations of the papillae, the mesenchymal papillae, which are intruding into the epithelium, and they are seen as elongated structures as if this is papillae formation. So these are also called intraepidermal papillae formation by the mesenchymal tissue, and this is indicative of acanthosis. This is subepithelial mesenchyme which is infiltrated by lymphocytes. Another term you will be coming across will be acanthosis, and acanthosis is increase in thickness of spinous layer. Many people take the term acanthosis and epithelial hyperplasia as synonym. Here we see that there is increase in the thickness of the spinous layer predominantly. So the spinous layer is increased. Again, we are seeing very good polarization of the nuclei. There is maturation of the cells which have a particular arrangement. This is called polarization of epithelium. Here we are seeing the dermal papillae intruding into the epithelium. And how we can recognize dermal papillae or mesenchymal papillae is by presence of capillaries and RBCs in the core of these structures. When hyperplasia, epithelial hyperplasia becomes very marked, extensive, and goes deep into the connective tissue, then it can be mistaken for malignancy. And this type of hyperplasia, as we are seeing here, is called pseudoepitheliomatous hyperplasia. We are seeing that the epithelium is growing deep into the mesenchyme as intercommunicating retiridges, but there is no loss of maturation of the cells. They are mature cells. There is no significant ATP. And this condition is very tricky. It has to be differentiated from invasive malignancy, and that will depend upon the degree of the cellular atypia we see in the epithelium. Now, where do we find pseudoepitheliomatous hyperplasia? This is found in cases of trauma or chronic infections and chronic inflammations like tuberculosis. In this case, we can see here that there is a granuloma formation. So this is a case of tuberculosis, and in response to this infection and chronic inflammation, there is marked elongation or hyperplasia of the epithelium mimicking malignancy. So this is pseudoepitheliomatous hyperplasia, and this is one condition we have to diagnose very carefully. Then we talk of hyperkeratosis. When there is increase in the thickness of the keratin layer, we say that this is hyperkeratosis. Here we can see that the keratin layer is compact and thickened. Again, here also in this slide, the keratin layer is thickened. This is one of the features of leukoplakia in oral cavity or chronic friction in other areas. And this is, here we can see that this is associated with acanthosis. So we have talked about acanthosis, we have talked about nuclear polarization, we have talked about polarity of the epithelium, and we have talked about hyperkeratosis. When hyperkeratosis is marked, we can see picture like this, where there are long columns of the keratin layer which are containing nuclei. So this is parakeratin, and sometimes this much proliferation leads to formation of horns. They become more and more compact in nature, and they present as horns on the surface of the epithelium. And generally it is seen in cases of varicose vulgaris where the superficial layers they grow into the horny layer or horns, and here underlying is the verruca vulgaris. So, what is polarization? Again, this is the parallel arrangement of the nuclei with basal placement of the nuclei. And opposite to polarization is the reverse polarity of the nuclei. In this, the nuclei are arranged away from the basal lamina, means they are towards the apical side of the epithelium. We can see there is a gap between the basal lamina and the nucleus. So this is reverse polarity of the nuclei, and this is generally seen in conditions of ameloblastoma or papillary thyroid carcinoma and some variants of papillary breast carcinoma. After having discussed epithelial hyperplasia, we come to the term dysplasia. What is dysplasia? Dysplasia is the disorderly growth of epithelium, and this is characterized by presence of increased cellularity, we can see here, and hyperchromasia. And what is hyperchromasia? Increase in the heterochromatin content of the nuclei. The nuclei appear darker in color as compared to the nuclei in normal areas, which appear vesicular. What are vesicular? The vesicular nuclei are the ones where the nuclear membrane is thick and the center of the nucleus is lighter. We can see or not see a nucleolus. So vesicular nuclei have paler center, while the hyperchromatic cells have the dark center as well as the periphery. So they look more blue in color as compared to the normal cells. Here we can see that even the cells which are present in the parakeratin layer, they are slightly larger in size and they are hyperchromatic in nature. So this is a sign of dysplasia of the epithelium. Dysplasia has been traditionally divided into three grades, that is the mild, moderate and severe, depending upon the amount of epithelium involved in the dysplastic process. Now here if we see this particular case, some people will call it mild dysplasia, while others may judge it as moderate dysplasia. Because of this confusion and inter-observer variation, now it is divided into low-grade dysplasia and high-grade dysplasia. The intermediate category of moderate has been deleted in the recent classification of dysplasias. Here we are talking of polarity of the cells, that they are arranged in a particular manner and they mature as they go towards the surface. And why this is important, that in malignancies or dysplasias, high-grade dysplasias or malignancies, this polarization of epithelium is lost. Now here we are seeing epithelium of a case of carcinoma in situ, where the basal cells are becoming as big as keratinocytes of the spinous layer, and the arrangement which we saw, normal arrangement, maturation, is getting lost. The cells in the upper layers also are showing hyperchromasia and nucleomegaly. What is nucleomegaly? Increase in the size of the nucleus is called nucleomegaly. We can see that these nuclei are much bigger than the nuclei we have seen in the epithelium in the previous slide. Here is the mitotic figure in the basal layer. The presence of mitotic figure in the upper layers of the epithelium is significant in diagnosis of dysplasia or carcinoma in situ or malignancy. Basal cell mitotic figures sometimes can be seen in normal epithelia also. Now, here is marked dysplasia. We can see that most of the cells are showing increase in size of the nuclei, hyperchromasia, and then there is irregular elongation of retirages here. We see that these cells are spouting from basal cell epithelium down into the mesenchymal tissue, but they are not yet detached from the epithelium, or they are not invading the stroma here. And this is a retirage with a narrow neck and a broad base, and this is called a teardrop shaped retirages. This is characteristic of invasive carcinoma, that if you find a teardrop cartilage, you must look for invasive malignancy. And lo and behold, here we have an area where the nest of the epithelial cells is lying free in the stroma. So this is invading the stroma. So this is a case of invasive malignancy. If invasion is limited to the upper part of the mesenchyme and not going deep, then it may be called microinvasive carcinoma or early invasion. Then another term you will be hearing very frequently is anisocytosis and anisonucleosis. What is that? Aniso means unequal. So when the size of the cell is unequal in a section, it is called anisocytosis, and when the size of the nucleus is unequal, it is called anisonucleosis. Another term which I will be discussing in this particular slide is pleomorphism. And what is pleomorphism? Different shapes and size of the cell. Now, let's look here. Let's think of the anisocytosis, that is the difference in the size of the cells. If we see this particular slide, we are seeing that some cells are small in size, some are large in size. So this difference in the size of the cell is anisocytosis. Similarly, here we see the nucleus, and this nucleus is much bigger. And this is small nucleus, this nucleus is much bigger. Difference in the size of the nuclei is called anisonucleosis. These are features of malignancy. Then pleomorphism. When we have different shapes and sizes, we can see very clearly that the size of the cells is varying very much in this case. And what about the shape? Some cells are looking, here we are seeing the oval nucleus, here we are seeing a spindly nucleus, this is a round nucleus. So there is a change in the shape of the cells which are ranging from spindle to oval to round or polyhedral. So this is pleomorphism, that is different shapes and size of the cells. What is mitosis? Mitosis is the duplication of the cells. The parent cell is a diploid cell with one chromosome each from the parent, and during mitosis the number of chromosomes doubles. There is a duplication of the chromosome, and this phase is called the prophase. In metaphase, the chromosomes, they align themselves along the center of the cell, and in anaphase they are pulled apart by the spindle and they go towards the pole of the cell. And in telophase, the two cells, they divide from each other, and we have two daughter cells from one parent cell, and this is the process of normal mitosis. The normal mitotic figures will show arrangement of the mitotic figure in the center in the metaphase. Here we are seeing a mitotic figure in the basal layer. Then we talk of abnormal mitosis figure. Abnormal mitosis is when cells are hyperploid in nature. They are not diploid, they are hyperploid in nature, and the number of microsomes are more, and they divide in a very irregular fashion. They can form a tri-star mitotic figure. They can form irregular, absolutely irregular mitotic figure. They can form a round irregular mitotic figure like here, and here we have a very dense chromatin mass just in the center, and this is a ring-shaped mitotic figure. So abnormal shapes of the mitotic figures are called abnormal mitosis, and this is a sign of malignancy. The higher the grade of malignancy, more number of abnormal mitotic figures. Now we must differentiate mitotic figures from apoptosis when we are counting the mitotic figures in the tumors. Now what is apoptosis? Apoptosis is the programmed cell death, and in this the nuclei are vesicular, but there is a cell, they become apoptotic and they become a dense mass. In this, it's a homogeneous mass, unlike mitosis. In mitosis, we can see the chromosomes separately, while in apoptosis, the mass is a homogeneous blue mass. So we must try to differentiate apoptotic figures from mitotic figures. Otherwise, our count of mitosis will become very high. Then there is a term which is anaplasia. What does anaplasia mean? Lack of cellular differentiation. When the tumor becomes high grade and it does not reproduce the cells from which it arose, then it is called anaplasia. Here we can see that the cells are very large, very pleomorphic, and they have high mitotic activity, abnormal figures. And by seeing these cells, we cannot say which is the cell of origin. It could be adenocarcinoma, it could be squamous carcinoma, it could even be a sarcoma. So when there is lack of differentiation of the malignant cells, then it is called anaplasia. Anaplasia is a feature of high-grade malignancy. Then another term sometimes we use in malignancy is cannibalism or entosis. And what is that? That is when a malignant cell engulfs a cell of the same type. It is called cannibalism. So it is a sign of malignancy in the milieu of malignant cells. Now here we see that this is a cell here and there is a phagocytosed another cell in the cytoplasm of this cell. Here again very clearly seen that this is a cell with the nucleus at the periphery and phagocytosed another cell in the cytoplasm. Another example, here we can see very clearly this is a malignant nucleus and this is a phagocytosed cell. So cannibalism is engulfing of the neoplastic cell by another neoplastic cell. So this is a sign of malignancy. Then we will be reading the term invasion of the stroma. What is invasion of the stroma? When the epithelial cells, they go beyond the confines of the basement membrane and they invade the underlying connective tissue, then it is called invasion of the stroma. Here we can see the nest of the cells are lying in the connective tissue. So this is invasion. Then this arrangement of the epithelium you have heard before in another lecture. I'll just go through these entities very quickly. The epithelial tumors can show architectural patterns like sheets and nests, particularly squamous cell carcinomas. When the arrangement of cells is in large groups, then it is called sheet. When they are in smaller groups, then it is called nests. So this is a sign of epithelial malignancy, particularly squamous cell carcinoma. Then very often you will be reading the term verrucous carcinoma in relation to skin carcinomas and oral carcinomas. Now, what is the verrucous pattern? This pattern shows exophytic papillary growth along with acanthosis and hyperkeratosis, marked acanthosis and hyperkeratosis. Examples of verrucous pattern are verrucous carcinoma, verrucous xanthoma, verrucous hyperplasia, leukoplakia, verrucous leukoplakia. So we are seeing that these papillae are broad. They are not very thin papillae and they do not have long papillary course till the end. They are more bulbous in nature here above as well as bulbous in nature down below. The rete ridges are bulbous, smooth, contoured and show minimum of atypia. So this is verrucous pattern. In contrast to this is the papillary pattern in which the processes are finger-like and they have a thin long fibrovascular core. And this pattern is seen in squamous papillomas and papillary carcinomas. So we can see that these are cut sections of the papillae. These are thinner than verrucous carcinoma papillae and they have a long fibrovascular core. Then follicular pattern. When the cells are arranged in follicles or masses arranged in follicular pattern, which is like this nest, large nest, irregular shaped. This is called follicular pattern. This is seen in tumors of odontogenic epithelium like ameloblastoma. Then you will come across the term of plexiform pattern. Plexiform when the interconnected thin strands or cords of tumor cells. As we see here, the tumor cells are forming thin cords with lot of mesenchymal tissue in between. So this is a plexiform pattern of growth. And again, this is also seen in more commonly in ameloblastomas. Then there can be metaplasia of one type of epithelium into the another type of epithelium, and that is called metaplasia. And in ameloblastoma, when the metaplasia is towards squamous type, then it is called acanthomatous or squamoid metaplasia. Here we see a ameloblastoma. It is showing squamous metaplasia. It is very commonly seen in endometrium also. Squamous metaplasia is a feature of endometrial carcinoma, and it can also be seen in benign endometrial glands many times. And when we say metaplasia, we must realize that metaplasia can be towards the intestinal type of mucosa also, as we see in Barrett's disease of esophagus, that the gastric type of glands they have metaplasia towards intestinal type of epithelium, and that is called Barrett's metaplasia. Then tumors can have basaloid pattern, that is characterized by round elongated cells present in nest with dense nuclei and scanty cytoplasm. These are like basal cells of the epithelium. Small cells with dense nuclei, minimal cytoplasm. They are basal cells but not in basal in position or origin, so basaloid. And these are seen in basal cell carcinoma, basal cell adenoma, and basal cell ameloblastoma. Then we have an alveolar pattern. It's a very characteristic pattern of alveolar soft part sarcoma. In this, it exhibits single layer of neoplastic cells that adhere to the dense fibrous septa like in lung alveolar appearance. If we see, we feel that this is a alveolar space of the lung. So the cells are attached to the fibrous septa at the periphery with a small little lumen in the center and giving appearance of a alveolar space of the lungs, so it is called alveolar pattern. And this is seen in malignant melanoma, alveolar rhabdomyosarcoma, and alveolar soft part sarcoma. Then we have nested pattern, where the cells lie in small groups. These are called nest or nested pattern. This is characteristic of neuroendocrine tumors. Then we have a gel balloon pattern which is seen in paragangliomas and pheochromocytomas. In this, gel balloon is a small nest of chromaffin cells which are separated by bands of fibrovascular stroma. Nested chromaffin cells separated by fibrovascular stroma. This is called gel balloon pattern and characteristic of paragangliomas. Then we have another pattern which we see in the tumors, especially in the cylindromas which occur on the scalp, where the cell groups they fit with each other like a jigsaw puzzle pattern. Here we see a jigsaw puzzle pattern in which these blocks they fit into each other. Here also we have this appearance. We can see the molding of the shape of this nest. It is molding according to the shape of this nest. So this is called jigsaw puzzle pattern, and this is characteristic of cylindroma. Then we have another pattern which is inverted lobular pattern. Now, inverted lobular pattern can be seen in keratoacanthoma, molluscum contagiosum, and inverted nasal papilloma. And in this, the surface epithelium is thrown into one or more irregular or cup-shaped. So this is a cup-shaped invagination of the epithelium into the mesenchyme that may show hyperplasia or dysplasia. Now, this is a case of keratoacanthoma, and in this there are two more terms I will be explaining. This is the crater or the cup-shaped space of the lesion or lobule, which is filled with keratin, and this is called crater. And this is the opening of the crater, and here we can see that there is a elongation of epithelium as if it is trying to enclose the hole or the crater. Again, here also there is a thin pointed extension of epithelium, and these are called epithelial lips, or this is called lipping of the tumor. So the lipping is characteristic of keratoacanthoma. So keratoacanthoma has lipping, has a crater which is filled with keratin and epithelial follicle inverted follicular epithelium, and this is inverted lobular pattern of the tumor. Then glandular tumors patterns have been discussed in detail in another lecture. I will just go through that. This tubular pattern is like single or double layer of proliferating epithelial cells forming elongated gland-like structures. Here, this is tubular pattern, and this is seen in adenoid cystic carcinoma, basal cell carcinoma, and many breast tumors and many more tumors. And this has been, why it is called tubular, because these are tubes, and we can see that this is the tube lumina, and that is how these glands look like, as if they are forming tubes. Cribriform pattern. Another pattern seen in the tumors is cribriform pattern, in which the cells are arranged in the form of multiple perforations like a sieve. We can see that there are multiple space or holes which resemble the sieve. Now here is the sieve with multiple holes, and this resembles this tumor, and this is characteristic of adenoid cystic carcinoma. Then we may have acinar pattern, microacinar pattern or acinar pattern, where the cells, they form small acini. We can see this is one acinus here, and this is seen in salivary gland tumors or in prostatic tumors or in pancreatic tumors. So this is the acinar pattern, where the cells, neoplastic cells, they are arranged in the form of acini. Then canalicular pattern. In this pattern, there are presence of cells in long elongated cords, presence of neoplastic cells proliferating and forming elongated and branching structures simulating channels. So these are the canaliculi, and this is seen in canalicular carcinoma and adenomas. So canaliculi, this is canalicular pattern. This is trabecular pattern. Neoplastic epithelium is arranged in the form of strands that are separated by connective tissue and form a network of cords of variable sizes. So this is cords of variable sizes. This is called trabecular pattern. The examples are hepatocellular carcinoma, generally presents in this pattern, and then we have polymorphous low-grade adenocarcinoma. They also have trabecular pattern, and many more tumors. As we go through the tumors, we will come to know that they are arranged in trabecular pattern. Biphasic pattern, where the cells are characterized by close association of epithelial and stromal components, as we see in pleomorphic adenoma. Here we see the mesenchymal tissue, which is closely intermingled with epithelial tissue. So this is the biphasic pattern. We see biphasic pattern in synovial sarcoma also, where the mesenchymal cells and epithelial cells, they merge with each other. Synovial sarcoma has biphasic pattern. Then desmoplastic reaction or desmoplasia. Here we have a tumor island, and this is surrounded by dense fibrous tissue. So this is marked desmoplastic reaction. Most of the tumors show desmoplasia, and that is one characteristic of differentiating the condition from benign. In benign tumors, there is no desmoplasia, while malignant tumors are characterized by dense laying down of the connective tissue. Then we come to mesenchymal tumors. There are certain patterns which are very popular. They have been discussed, but I'll just go through because they are very important. Storiform pattern. This is characterized by presence of neoplastic cells that radiate away from the center like wheel spokes. You get appearance that these are wheel spokes, and or a cartwheel, and this whirling pattern is present. So this is a storiform pattern, and this is seen in fibromatosis, DFSP, malignant fibrous histiocytomas. This is a very characteristic storiform pattern. Then we have the mat pattern or the herringbone pattern, where the cells, they appear as if they are meeting in the center. They are in the fascicles, but they appear to meet each other in the center like a mat. So this pattern is a herringbone pattern, and this is seen in fibrosarcomas or mat pattern. Then we have the fascicular pattern, where the cells are arranged in long parallel bundles They may be lying parallel or they may be intersecting each other, and this is seen in leiomyomas and leiomyosarcomas. Then we have a palisading pattern where the nuclei they align themselves together, forming a palisade, and this is characteristic of schwannomas. So nuclear palisading is characteristic arrangement of the seen in schwannomas. Then we have the staghorn pattern. The cells in this pattern range from round to oval to slightly spindle. It shows a rich vascular pattern composed of large and small vessels lined by single layer of flattened epithelium and that are typically angulated or forked, forming a characteristic staghorn pattern. So here we see that these are irregular shape with pointed extensions resembling the staghorn of a deer. So this is called staghorn pattern. Example, the characteristic example of this pattern is hemangiopericytoma. Now, starry sky appearance. Here is the starry sky we see at night, and here is the appearance of a tumor with the starry sky appearance, and this is characteristic of Burkitt's lymphoma. Because of the high degree of cell death, the dead cells are taken up by phagocytes, and they give this appearance of starry sky. Then another term which we use is emperipolysis. Emperipolysis when there is phagocytosis of the lymphocytes by histiocytic cells, and this is characteristic of Rosai-Dorfman disease. Here we see a large histiocytic cell with the lymphocyte inside, and here we are seeing very heavy emperipolysis where each cell is containing more than 4 or 5 lymphocytes. So this emperipolysis is seen in many tumors but is characteristic of Rosai-Dorfman disease. And then lastly, we have a pattern in a benign mesenchymal tumor which is called Chinese letter pattern. This is characteristic of fibrous dysplasia where the spicules of the osteoid material they have various shapes like Chinese letters. These are the thin bony tuberculi which are curved and they appear like Chinese letters. So this is characteristic of fibrous dysplasia. Then some terms which we see in non-neoplastic conditions, as I have discussed before, epithelial hyperplasia term is one which we see in leukoplakia of the oral cavity. Then the term is leukoplakia or erythroplakia. Leukoplakia is a clinical term, and erythroplakia again is a clinical term. In pathology, it is called hyperplasia with dysplasia. So we never use the term leukoplakia in pathology. We use epithelial hyperplasia with dysplasia or without dysplasia. In erythroplakia, there can be varying degree of dysplasia or even microinvasive carcinoma. So here we can see that there is dysplastic changes are increasing in amount as compared to this side. So this is a case of erythroplakia clinically, but we will call it varying degree of dysplasias compatible with erythroplakia. Then there is a term sawtooth pattern of the retinoides elongation. We have the sawtooth. Ara होते हैं ना ara जिसे लकड़ी काटते हैं. It has got teeth which are like this, and there is a condition in which the retinal ridges are long, elongated, thin, and appear like saw. So this is sawtooth appearance of the retinal ridges, which is characteristic of lichen planus. Then another term is elephant foot retinoides. The retinoides are broad, very wide, and this type of retinoides are seen in varicose hyperplasia. So this is elephant foot type of retinoides in varicose hyperplasia. Then we have an arcading pattern. This is a term used for describing the radicular cyst or the periapical cyst where the epithelial retinoides they form arcades like this, enclosing a connective tissue area. Here we have a arcading pattern. This is arcading pattern. These are arcades. And this is exactly how we are seeing here that the elongated retinoides are enclosing the pores of connective tissue, giving a arcading pattern. and this is characteristic of periapical cyst or reticular cyst. Then another term we come across is acantholysis. What is acantholysis? Lysis of desmosomes or cell separation, so the cells become detached from each other and they lie in the central cavity, vesicular or bullous cavity, and this is called acantholysis. Acanthocyte means spindly prickle cells, and lysis means lysis of the prickles, so these cells become rounded and they have denser nuclei, round shape, dense nuclei, and these are acantholytic cells, and it is a characteristic feature of pemphigus group of disorders, particularly pemphigus vulgaris. So, I thank you very much for going through this very patiently. Thank you very much again.